Hello and welcome. My name is Dr. David Cooke, and I'm the head of the section of jaw and thoracic surgery in the Department of Surgery here at UC Davis. Today, I'm excited to talk to you about some of our very fascinating, interesting work in patient-focused research in our section of jaw and thoracic surgery, entitled Engaging Our Patients, Clinical Care Processes and Patient Engagement to Improve Thoracic Surgical Outcomes. I have no financial disclosures that are relevant to this discussion. Is there a cure for lung cancer? The answer emphatically is yes. It is called surgery for early stage disease. As you can see here, these lines show different stages of lung cancer after their treatment with surgery. For stage 0, stage 1, at 1 year and 2 years, the survival after therapeutic surgery for lung cancer for early stage is excellent. As the stage is advanced, the survival after lung cancer therapy decreases. Yet, surgery is not often the choice for patients with early stage lung cancer. And why is that? Well, A, thoracic surgery is high risk with high complication rates, and also patients may be afraid of surgery. And why are patients afraid of surgery? We must look at the outcomes. With surgery, there's a risk of death, or what we call mortality. And there's other risks, which collectively call morbidity, but things such as respiratory impairment, blood clots, pain, impairment of activities, and importantly, emotional distress, which can occur after any therapy, but especially surgery. Now, what are the variables that influence surgical outcomes? How do we get excellent outcomes and avoid some of those morbidities that we talked about? There are hospital-level variables such as procedure volume. How many cases or procedures of a particular type of surgery is done in a hospital? There is the concept of failure to rescue. If an individual undergoes a complication after surgery, what is the likelihood of that facility or that doctor to rescue them from that complication? And then there are surgeon-level variables. How many surgeries has this particular doctor performed in their career? And what type of surgeon are they? Are they the type of surgeon that really should be performing that surgery? This is a very interesting graph of some of our research done here at UC Davis, looking at the California Cancer Registry, looking at patients with early stage lung cancer who have undergone surgery. The top line are patients who have undergone surgery at high volume centers, so centers that do a lot of lung surgery. The middle line are patients who have undergone surgery at middle volume hospitals, and the red line are patients who have undergone surgery at low volume hospitals. And what we found in this study is that patients who have undergone surgery at high volume hospitals have long-term cancer-specific survival. So even 5 years out of their surgery, having surgery at a high volume hospital affords a survival advantage after lung cancer surgery. But is volume the only answer? Are high volume centers and surgeons doing something differently? Is there a magic dust? And can that magic dust be bottled and distributed? And can the patients themselves contribute to these results? Can postoperative pathways be the magic dust for optimal outcomes? This is another study that our group has produced. It's called Attempting to Rescue, an esophagectomy education program and postoperative pathway improves outcomes and costs. Now, an esophagectomy is the removal of the esophagus for lung cancer. In order to put a patient back together so they can eat again, the stomach is brought up behind the heart and sewn to the remaining esophagus. This is varsity level surgery. It's big surgery and it has a high complication rate. Studies have shown that patients at high volume centers who do a lot of this surgery do better and do well. Now, this is an example of one of our postoperative clinical pathways. I'm not expecting you to be able to read this, the font is very small, but it shows you that there's a lot of information packed in here and guidelines and instructions to help our care team best take care of patients. There's an individual page for each day after the surgery. For instance, there's a reminder of giving medication to help prevent blood clots. There's a reminder to perform respiratory physical therapy to help prevent pneumonia. And there's a reminder for other things to help prevent complication. These boxes here represent a respiratory therapy pathway that each patient undergoes. And we've shown that if patients undergo this pathway, the risk of lung complications are markedly reduced. The summary of our findings, which was reported at a national meeting, was that the postoperative pathways in esophagectomy reduced complications, including pulmonary complications or lung complications, and blood clots to the lung and legs, also called DVT and PE. It reduced the need for returning back to the operating room during that hospitalization. It reduced the number of patients needing to come back and be readmitted to the hospital after their discharge to home from surgery. And it reduced the overall cost of care within the hospital. Now, we feel that the improvements in pulmonary complications were a direct result and with communication with our respiratory therapists and the pulmonary and respiratory therapy protocols that were built into the pathway. We also felt that the reduced return to the hospital after discharge was a direct result of reducing complications and rescuing patients from the complications. And we felt that the reduction in hospital costs was a result of standardization of our practices and reducing unneeded tests and imaging studies. Now, we've adapted those pathways to all of our types of thoracic surgery, including lung cancer surgery, and that has afforded our section of general thoracic surgery excellent outcomes as measured by multiple national databases, such as the ACS-NSQIP and the Society of Thoracic Surgeons database. But where to next? We feel that patients and their families and friends can be engaged in their own care. We want to develop patient and family-centered pathways where patients become participatory in their care, and we hope to re-engineer our successful pathways so patients focus on the clinical outcomes most important to them, whether it's ability to breathe without dysfunction, whether it's avoiding blood clots in the legs or that extend up to the lungs after surgery. Patient engagement is the blockbuster drug of the century. Those are headlines that are throughout newspapers and magazines in 2014 and soon to be 2015. In fact, Devin Gross, the CEO of what's called Emmy Solutions, a really fascinating and novel patient support platform that we use here at UC Davis, stated, people, patients, employees, consumers, are the most underutilized resource in the healthcare system. So what we did, we put together a research program that's been funded by the Patient-Centered Outcomes Research Institute, large funding institute that was developed by the Affordable Care Act. And the goal of this research study is to identify outcomes that are most important to patients and their families after lung cancer surgery and best optimize those outcomes. We did this by conducting Twitter chats using an established social media platform called Lung Cancer Social Media, conducting in-person focus groups with lung cancer patients and family members, and also healthcare providers. And we are developing a community stakeholder advisory panel called a CSAP, composed of patients, family members, lung cancer advocacy group representatives, and care providers. So let's talk a little bit about these Twitter chats. So Lung Cancer Social Media Chat, or LCSM Chat, you could identify this at lcsmchat.com, is a novel patient engagement platform which utilizes Twitter to introduce patients and other stakeholders to evidence-based best practices in the care of lung cancer patients. LCSM was first used in June of 2013. I co-developed this concept with other stakeholders who I'll introduce later. Every other Thursday, 1-hour tweet chats at 5 p.m. Pacific time are held. The focus of these Twitter chats are to use social media in an innovative manner to educate and develop public support to end the stigma and facilitate successful treatment for lung cancer. As of December of 2014, using the hashtag LCSM, there have been over 11,000 participants, 105,000 tweets, and over 270 million impressions. In fact, Tweeted Facts for November 2014 Lung Cancer Awareness Month was very successful, and there was over 11,000 tweets and 37 million impressions introducing patients and other stakeholders to evidence-based best practices for the care of lung cancer patients. What we did was we then produced transcripts of those chats and did what we call content analysis, which is a study term used in qualitative medicine. And we identified important themes that were revealed in these chats. One important theme was the incidence of pain after lung cancer surgery. This was very informative to us because 70% of our lung cancer surgery at UC Davis is performed minimally invasively, with small incisions and high-definition cameras. Now, compared to the way we used to do lung cancer surgery maybe 5, 10 years ago, and the way it's done throughout many parts of the country through large incisions and spreading in the ribs, the minimally invasive approach affords far less pain, and patients are able to return to work faster. Yet, patients don't understand the way we used to do it. All they know is how we do it now. And although it's much less painful than how we used to do it, it is still painful to patients, and they wanted us to know that. Patients also wanted to be free of any respiratory abnormalities after lung cancer surgery. Next, we conducted in-person focus groups with lung cancer patients and their family members. And we also performed healthcare provider focus groups, separate focus groups talking with nurses, physical therapists, pain pharmacists, and other allied health care professionals who are dedicated to the care of lung cancer patients. Using these focus groups, we were able to identify additional themes that were important to patients undergoing lung cancer surgery. And then we asked our healthcare providers to comment on the care of lung cancer surgery patients from their own unique perspectives as healthcare providers, comment on the patient-centered themes identified from social media, as well as the in-person patient focus groups from a healthcare provider perspective, and then also to apply some of their patient perspective themes and their own opinions that we identified to the postoperative lung surgery pathways, and then to the overall global care of lung cancer surgery patients here at UC Davis. All a means to improve outcomes after lung cancer surgery and optimize the care for our patients. Finally, we are in the process of developing a community stakeholder advisory panel. This will be composed of patients and their family members and friends, a representative from a lung cancer advocacy group, and other care providers and researchers, including a sociologist. The charge of the UC Davis Community Stakeholder Advisory Panel will be to re-engineer our postoperative pathways to a patient-centered postoperative pathway. They will also develop a trial comparing the patient-centered postoperative pathway to best practices. And finally, the CSAP will serve as patient-centered outcomes research infrastructure to develop future patient-centered studies and projects here at UC Davis. Also, with lung cancer social media, we have developed a working core governing group, and I'll introduce them in a bit. Via our social media platforms and public medical communication, we will develop two-way learning so healthcare providers can understand the challenges and biases and concerns, i.e. lung cancer stigma, that patients with lung cancer and their families go through. We will introduce strategies for evidence-based decision-making to patients and their families. We will help patients and families understand accurately the concepts of risk and benefit and percent outcomes in lung cancer treatment. And finally, lung cancer social media, LCSM, will be used to disseminate evidence-based information on the treatment of lung cancer and the results of comparative effectiveness research and other clinical trials and therapeutic clinical trials that may benefit patients with lung cancer. I have many thanks in regards to the research that we are doing here at UC Davis in our section of GI and thoracic surgery. I would like to thank our research partners, Dr. Deborah Paternini, who's a sociologist critical in our patient-centered outcomes research here at UC Davis, and then the core governing group of lung cancer social media. That includes Veronica Conway, Janet Freeman-Daly, Dina Hendrickson, and Dr. Jack West. I'd like to thank Dr. Elizabeth David, who is a surgical partner at UC Davis in thoracic surgery and a health services research of great accomplishment. I'd like to thank the UC Davis Center for Healthcare Policy and Research, which is our health services hub here at UC Davis. And finally, we'd like to thank the Patient-Centered Outcomes Research Institute for funding much of this work and allowing us to develop the infrastructure here that will greatly develop and serve our section of thoracic surgery, but most importantly, serve our patients of our UC Davis community and patients with lung cancer, esophageal cancer, and other thoracic diseases throughout the state of California. In summary, the UC Davis section of thoracic surgery has a robust research program in health services and patient outcomes research, and we're also always looking to partner with our academic colleagues throughout the nation as well as our patients and their families to help improve outcomes for our community. Thank you, and thank you for taking the time to listen about our work.